Last is the Avalon cannula. You guys are familiar with the Avalon cannula that we use sometimes as a one cannula for VV Ecmo. Usually the arterial cannula should lie medial to the return cannula should lie medial to the inflow cannula, just like the carotid and IG relationship. Okay. The reason I'm saying that is because we had a guy that the relationship was distorted and he was recirculating like crazy. So just always check and make sure that the return is medial, the neck to the inflow. Now, classically on echo, you should see the tip of the cannula lying in the IVC. It should be 3-4 centimeters in IVC. If it's 1 centimeter in IVC, I'll be a bit nervous that it's going to pop off.
There are 10 minutes
remaining. And then the other thing is you should see the outflow opening, which is going to be here in this area, jet directed toward the tricuspid valve, toward the RV. If it's to the other direction, then the cannula needs rotation. Just rotation. Not so usually the surgeon will ask you, is it pushing, pulling, or is it rotation, or is it both? So you have to decide. Now, this is how a subcostal IVC window looks like, and you can see the cannula occupying the IVC end up to this point. Okay. I would say this is a bit pushed in too much. However, this is the outflow opening. You can see it clearly here, and this is the tricuspid valve RV. So maybe it's not too bad, but maybe pulling it a little bit would be helpful. It's just to show you that transthoracic echo can be helpful to ensure. That's it, guys. Any questions? Thank you so much. Just brief. Yeah, go ahead.
The inflow ports of the Avalon as compared to where jet is going, is it aligning? Is it exactly the same plane, or is the inflow ports?
So there are two, one in SVC, one in IVC. The one in SVC, it's just the opening, the distal end, and the one in SVC, it's an opening in the middle of the cannula, just like the outflow.
It's like perpendicular to the process of the cannula itself,
right?
Versus the inflow, which would be parallel.
We never try to visualize the SVC portion. We only try to visualize where does the cannula end into the IVC, and where does the outflow jet go. So you want the outflow jet going to the tricuspid valve. You want the distal end of the cannula ending 2 to 3 centimeters into the IVC, basically.
And so when you're doing that approach, I mean, when you're actually guiding an Avalon cannula, is it reasonable to use TT in most cases, or do you have to go to TT?
If the view is beautiful,
yeah,
I can tell you here the surgeons will, because of the comfort level, they would want a TE, and they would want most of the time to do it in OR.
Okay.
Have we been, Rex, doing a lot of cannulas in CVICU? No. In OR. Yeah.
No OR. Oh, okay.
Right. So
it's just, I mean, it's better for everybody, right? It's more
It's more of a controlled environment.
Yeah, it's sterile, and all the equipment's there. If they rip something or need something extra, the nurses have the stuff that's there. It's just waiting. They've had one Avalon cannula that's functionally IVC.
Oh yeah, really? Wow. Okay.
less recirculation than the two cannulas, though.
Yes.
Definitely, but very position dependent. That's a problem.
Yeah.
And physioing the patient and moving the patient is a problem.
It's a problem, yeah.
Like
Much
this guy
like
with
our,
burn, I don't know how they're going to physio him.
Much like our CRT.
Right.
Yeah.
Absolutely.
And one of the points I just wanted to mention is that just for the outside sites, I'm not sure if they were necessarily following the thread, but when a patient comes in and they have, like you said, chest pain, they have acute coronary, like what looks like acute coronary syndrome, they have a pericardial effusion, that kind of constellation of problems is pretty concerning, right?
Well, I would think about dissection if I see that.
Yes.
Definitely.
Yeah. And I think in the literature, there's certainly been many reported cases where it has been missed initially.
Yeah. Let's face it, what can cause acute chest pain, troponin positive, and pericardial effusion? Two things only. I can't think of anything else. Two things I can think about. So pericarditis and dissection. So when I see pericardial effusion, chest pain, and troponin, I think about these two.